The occipital bone is formed by three different regions: the squamous region, lateral region, and basilar region just at the center. From the endocranial perspective, or an endocranial view, we can identify several landmarks. In this case, we're going to start with the internal occipital protuberance that is going to lie at the same axial level of the external occipital protuberance. And then we have the impressions of big vascular components that are going to be lying over the occipital bone in anteriorly and superiorly, pardon me. What we're seeing is the superior sagittal sinus, and inferiorly is impression of the occipital sinus. Laterally, we're going to have both transverse sinuses running over the squamous portion of the occipital bone, and this impression is going to help us to identify the infratentorial and supratentorial spaces. And just anterior to the squamous portion, we see the foramen magnum, which lies in between the three regions of the occipital bone. What we're seeing here is the jugular notch, which is formed by the projection of the jugular tubercle. It's basically the anterior limit of this tubercle. Anterior and medial, we're seeing the hypoglossal canal, also called the anterior condyloid canal, and we see in each one of these two lateral regions the condyles. So the condyles are gonna be part of the occipital-atlantal joint, and the condyles are ovoid structures that are going to be running from posterior and lateral to anterior and medial. And as I mentioned previously, there's going to be an anterior foramen, which is a hypoglossal foramen, and it usually lies between the junction of the first and second third of the condyle. Posteriorly, what we see here is the condyloid canal, which is the place through one of the emissary veins are going to be traveling. And as previously mentioned, on the lateral region, we're going to find the jugular process that in its anterior segment is going to have the anterior notch, which is the posterior portion of a jugular foramen. Just to remember that jugular foramen is the place where the internal jugular vein and the inferior complex named 9th, 10th, and 11th cranial nerves are going to be traveling through, and the jugular foramen lies posteriorly and slightly lateral to the hypoglossal canal. Now moving to towards a posterior extracranial view, we see that there are several landmarks related to muscular and ligamentous attachment. These landmarks can be identified thanks to protuberances as well. And from inferior perspective, we see that the inferior nuchal line it can be identified, and superiorly we see a superior nuchal line. Superior to that nuchal line, we have the highest nuchal line. Just in the midline, we have the external protuberance, also called the anion, and medially there's going to be a medial nuchal line. And that's an overview of the occipital bone which is gonna be part of the craniocervical junction. Lying in a transitional region provides unique characteristics to the atlas, which is formed by two arches, an anterior and posterior arch, separated by lateral masses which have transverse processes. The anterior arch has a protrusion, also called an anterior tubercle. This is the place that is going to serve as an attachment point for the anterior longitudinal ligament and the superior oblique fibers of the longus colli. Then we have the posterior arch, which from a superior perspective we can see that the posterior arch forms the posterior 2/3 of the circumference of the vertebral foramen. The posterior arch also has a tubercle, which is the posterior tubercle. The posterior tubercle serves as an attachment point for the rectus minor muscle and the occipital membrane. Both ligamenta flava also attaches to the inferior borders of this region. Laterally, we're going to have two groups, which are also called sulcus arteriosus. These two groups serve as a place where the vertebral artery, the third segment of the vertebral artery is going to be resting on, and it is important to analyze this area if any approach involving the vertebral artery is planning to be taken. Around 32 to 37% of the times there could be a bone made of bridge covering the artery called ponticulus posticus. Now, anteriorly, we have the superior articular surface and the inferior articular surface. The superior articular surface forms the atlanto-occipital articulation or joint, and it has a bigger diameter and a more and runs in a more oblique way, having a broad, larger base posteriorly and a smaller anterior diameter, and that's due to the shape of the occipital condyles. And we move inferiorly, and if we move inferiorly, we see that the inferior articular surface, which is going to be the place for the articulation between atlas and axis, it is running, or it has a more parasagittal direction, and in between these two articular surfaces, we're going to have this, which is the lateral mass. The lateral masses can be found between the anterior and posterior arches, and these are also the weakest points of the vertebra, and it's commonly it's a common place for fracture called Jefferson's fracture. Medial to this structure, we have the colliculus atlantis that serves as an attachment for the transverse ligament. Posterior to the colliculus atlantis, we have the sulcus atlantis, that is foramen where one of a branch from the vertebral artery is going to be traveling through, and is going to be providing blood supply to the lateral masses of C1. Lateral to the lateral masses, we have the transverse foramen, and more laterally we have the transverse process. As we mentioned previously, the transverse foramen is going to be a foramen through which the vertebral artery is going to be traveling through. It's going to go from a more vertical direction, oblique, around 45 degrees, and it's going to make a turn after passing through this foramen, and it's going to take a more horizontal direction. Something particular about the transverse process of C1 is that it only has one tubercle, whereas the other cervical vertebrae are going to have an anterior and posterior tubercle. The atlas has also unique anatomical features. Starting anteriorly from the body, there's a superior projection named odontoid process or dens. If we move superiorly, we're going to find the apex of the odontoid process, and if we move anteriorly, the anterior articular facet, and posteriorly the posterior articular facet. So anteriorly, the anterior articular facet articulates with the posterior articular facet of the anterior arcs of C1, whereas the posterior articular facet is gonna serve as a place for the attachment of the transverse ligament. Moving superiorly and laterally, we see these two protrusions that are going to be the place for the attachment of both alar ligaments, right and left, and superiorly again the apex of the odontoid process, which is going to be the attachment point for the apical ligament. Now moving laterally, we have the superior articular surface, which is which has a big surface that is running obliquely from lateral to medial, and it has a more horizontal direction than the inferior articular surface that it lies more vertically, and is practically emerging from the junction of the lamina and the pedicle. The pedicle lies just posterior to the superior articular process, and in between both articular processes, the superior and inferior, we have the pars interarticularis. Moving posteriorly, we have the lamina, and the lamina it's thicker than the rest of the subaxial lamina, and anteriorly we have the spinal canal or the vertebral foramen, and both lamina are joined by the spinous process, which is a bifid spinous process and is the second most prominent spinous process of the cervical region. Inferiorly, we have the inferior surface of the body of C2 that has an anterior projection for the interbody articulation with C3. Laterally, we have the transverse process, which is shorter and smaller than the transverse process of the rest of the cervical vertebrae. Medial to the transverse process, we have the transverse foramen, which is the place in which the vertebral artery is going to follow a medial lateral angle, and it's going to travel towards the most superior transverse process of C1. What we see right here is a 3D representation of a typical vertebra. This is C4, and first we can see the vertebral body, which is a small vertebral body with a broad coronal diameter. This is the superior end plate, the inferior end plate, and the superior end plate is going to have two lateral projections, which are the uncinate processes. these processes are going to be just medial to the vertebral artery, which is going to run through the transverse foramen. Posteriorly, we have the vertebral arch, which is connected to the vertebral body by the pedicles. And anterior to the pedicle, we have the transverse process that has an anterior tubercle and posterior tubercle. In between these tubercles, we see the connection happening by an intertubercular lamella. Just posterior to the intertubercular lamella, we see a groove, which is the spinal groove. It is the place on which a spinal nerve is going to be resting on. Superior to the pedicle, we can identify the superior vertebral notch. Inferiorly, the inferior vertebral notch. Posterior to the pedicle, we see the superior articular process and the inferior articular process, both running from inferior and posterior to anterior and superior. In between these articular processes, there's mass, which are both lateral masses, and posterior to the lateral mass, we can identify the lamina. Both laminae are going to be connected by a spinous process. From a superior view, we can identify the spinal canal or vertebral foramen, which has a triangular shape. And that's the anatomy of a typical cervical vertebra. Now we're going to go over the characteristics of another unique cervical vertebra, which is C7. Starting out with the body, which since this is a transitional vertebra, we see that the transverse diameters tend to get larger than the sagittal diameter, and it preserves the unique characteristic of an uncinate process that again lies just medial to the vertebral artery, which is going to travel through the transverse foramen. And moving posteriorly, we have the vertebral arch, which is going to be connected again by these short pedicles, and anteriorly this very small and thin transverse process with an anterior tubercle connected by an intertubercular lamella and a prominent posterior tubercle. Again, the intertubercular lamella is going to be the lateral limit of the spinal nerve groove. And if we move medially, the spinal nerve root is going to be coming out of the superior ventral notch. And at the inferior portion of the pedicle, you can see the inferior vertebral notch. Now, the superior articular process and the inferior articular process, they tend to go in a more coronal direction, meaning that they tend to go more vertical than the upper segments of the cervical region. And another we already mentioned also the lateral mass, which is in between the superior articular and inferior articular process. But moving posteriorly, we see that the lamina tends to go shorter, and that's also one of the things that we're gonna see in the inferior levels of the that are gonna be part of the thoracic region, as well as this prominent spinous process. So that means that what we're seeing here is the articular processes tend to get a more coronal projection, again meaning more vertical. The lamina tend to get shorter, but the spinous process is gonna get longer, and as we're gonna see later on, the thoracic region, they're gonna tend to go more vertical as we move to the inferior levels. So again, the spinous process of C7 is the most prominent process, the most prominent spinous process of the cervical region, and is usually a landmark that can be uh, palpable at the physical examination. Another thing that is worthwhile to mention is, and this can be found regularly on C7, is the absence or the atresia of the transverse foramen. If we remember, the transverse foramen of C7, it usually lies inferior to the axis of the vertebral artery to the conventional level, which is the transverse foramen of C6. So that means that usually these foramina are not hosting any vessel or nerve, and that's why a lot of times the foramen, one of the foramina or both, are gonna be closed or small, and that's the anatomy of C7. This 3D model offers an overview of the ligaments related to the odontoid process. So let's start with the cruciform ligament that is formed by a transverse ligament that is attaching to, it's going to be attaching to the colliculus atlantis, from colliculus atlantis to colliculus atlantis of C1. And it's going to be, this cruciform ligament is going to have a superior longitudinal and inferior longitudinal band. The superior longitudinal band attaches inferiorly to the transverse ligament itself and runs towards the basilar portion of the occipital bone, whereas the inferior longitudinal band attaches superiorly to the transverse ligament and inferiorly to the posterior surface of C2. Then anteriorly and running in an oblique direction, we have the alar ligaments. These ligaments are going to be attaching to the posterior lateral aspect of the odontoid process, and going to be running laterally and attaching to the occipital condyles. These ligaments are going to serve or are going to help to limit the contralateral axial rotation. And anterior to the superior longitudinal band, we have the apical ligament. The apical ligament attaches to the posterior surface of the odontoid process and runs anteriorly to the bastion, where it merges with the fibers of the superior longitudinal band of the cruciform ligament. And this ligament prevents the vertical translation and anterior shearing of the occipital bone. In this area, particularly the apical, where the apical ligament and the superior longitudinal band and atlanto-occipital membrane lie, we can find a structure called the apical cave, which is an area covered by neurovascular structures such as venous plexus, recurrent meningeal branches of C2 and C1, and the apical odontoid arterial arcade. Great. This 3D model allows us to explore the craniocervical junction from a posterior perspective, and the main neurovascular components, as well as the suboccipital group of muscles. So let's start identifying the osseous components. What we see here is the posterior arch of atlas. Inferiorly, we can identify the lamina of the axis and the bifid spinous process of the axis. Moving superficially and superiorly, we're going to identify superficial nerves, medially the greater occipital nerve, which is going to be coming out of the dorsal ramus of C2, and laterally the lesser occipital nerve, which is going to be coming out of C2 and C3. Superiorly, we visualize the inium, which is external occipital protuberance, and lies at the same axial level of the superior nuchal line. And also we see the most superficial segment of the occipital artery, in this case the right and left occipital arteries. This is a great opportunity as well to identify properly the course of the proximal portion of the occipital artery, also the suboccipital portion of the occipital artery, lying in between the posterior belly of the digastric muscle and the superior oblique muscle. What we're seeing here is after removing the right lamina of C3, is the exposure of the dura, and the dural sleeve covering the nerve root. And now we move towards the suboccipital muscles. And just to remember as well, in this region, we're going to find the posterior atlanto-occipital membrane, which runs from the posterior arch to the opisthum, which is the posterior portion of the foramen magnum. What we're seeing here is the rectus capitis minor, which is going to have a superior attachment on the inferior nuchal line and inferior attachment on the posterior arch of C1. Laterally, we have the rectus capitis major, which is attaching superiorly to the inferior nuchal line and inferiorly to the spinous process of C2. If we move laterally, we see the obliquus capitis superior muscle, which is attaching to the most lateral portion of the inferior nuchal line and has an inferior attachment on the lateral mass of C1. Inferiorly, you can identify the obliquus capitis inferior, which is attaching superiorly and anteriorly on the lateral mass of C1 and posteriorly on the spinous process of C2. So after defining the muscles, we can identify the suboccipital triangle and the structure that encompasses or that are within this triangle. One of the major structures is the V3 segment of the vertebral artery, and we can identify here the sulcus arteriosus of the atlas and the horizontal portion of the vertebral artery. Just posterior to the vertebral artery, we're going to find the C1 nerve root or the suboccipital nerve, and we can also see some branches from the occipital artery that are usually forming an anastomosis with the vertebral artery. It's important to remember that there's also vertebral plexus in this region that is likely to bleed when exposing this area. From the other side, we can identify the right vertebral artery. Again, V3 segment with a horizontal portion and a more vertical portion that is going to be coming out of the transverse foramen of C2 and entering the transverse foramen of C1 right here within the transverse process of C1, and it's going to rest over the sulcus arteriosus. Inferiorly, we see the C2 nerve root, and we can see the C3 and its connections with C2 to form the lesser occipital nerve. So let's explore quickly an actual cut at the upper subaxial level meaning what we're seeing here is the body of C7. It's going to start with identifying structures anteriorly, starting with the mandible, moving posteriorly to the root of the tongue, the epiglottis, and the pharyngeal constrictor. It's important to comment that the upper portion of the pharyngeal constrictor is attached to the pharyngeal tubercle of the basilar portion of the occipital bone. This is a great view to understand the different neurovascular and visceral components when approaching either anteriorly or posteriorly, in this case the upper subaxial level. So let's go back to the anatomy, and lateral to the root of the tongue, and just medial, in this case, to the submandibular gland. What we can see here is the hypoglossal nerve that it is worthwhile to remember that there's a communication of this nerve with the cervical plexus via the ansa cervicalis. And again, just posteriorly, we're gonna start identifying vessels with a big caliber, starting with the retromandibular vein, which is a direct branch of the jugular vein. We see the internal jugular vein laterally, and medially we can identify anteriorly the external carotid artery and posteriorly the internal carotid artery. Just in between these vessels, the internal jugular vein and both carotid arteries, we can identify the vagus. And let's also just mention, if we remember, we when we were visualizing the anatomy of the occipital bone, we identified the jugular notch, and the most posterior portion of the jugular foramen is the vascular portion, meaning that the internal jugular vein is going to travel posterior, and then it's going to go lateral to the neural component, that is the inferior complex. And we also know that the vagus nerve forms part of the inferior complex. So let's move medially, and what we can see here is the sympathetic trunk, which is usually like in a very intimate relationship with the carotid artery. In this case, we separate a little bit the structure just to properly identify them. And moving medially towards a muscular compartment, but we saw laterally there was a vascular compartment. We see the longus colli, that if we remember, the superior attachment of the longus colli is going to be at the anterior tubercle of the atlas. Now, lateral to the longus colli, we have the longus capitis muscle, and then we move posteriorly to identify the superior articular facet of C4. What we see right here is the left vertebral artery and right vertebral artery. One of the muscles that we explored before during the musculature, or the muscles associated with the spine, is the semispinalis capitis that we mentioned is lies at a deep layer, the splenius capitis muscle, and the longissimus capitis muscle, which lies more superficially. And one of the muscles that serves as a landmark for anterolateral approaches, the sternocleidomastoid muscle. So this is a muscle that is usually retracted, but let's remember that there's an intimate relationship between this muscle and the spinal cranial nerve, the 11th nerve. And it is conventionally this route, the one that is taken just anterior to the sternocleidomastoid muscle, separating laterally the vascular component and mobilizing medially the visceral component, in this case the trachea and the esophagus, in order to reach the anterior portion of the cervical region.